Everything else in the chest.
Thank you. So good morning, everybody. And it is my real pleasure to introduce and guide you through the recent data with immunotherapy for other thoracic malignancies. And I will talk about small cell lung cancer and mesothelioma. We know that small cell lung cancer can be staged as a limited disease and extensive disease. And I would like you to have a look at the overall survival of these diseases. The 5 years overall survival of extensive disease, small cell lung cancer, is about 1%. And the 5 years overall survival of mesothelioma is below 5%. So we need to do something. We need to improve the treatment of these diseases. And this is what I'm going to show you now. First of all, how do we treat today, or how have we treated until today these cancers? For small cell lung cancer, limited disease or extensive disease, chemotherapy with a platinum-based chemotherapy is the standard of care. And if the question is which chemotherapy or which platinum, well, you see these are the results of a meta-analysis comparing either cisplatin or carboplatin. Both stages, limited and extensive, there is no significant differences. So we know for both stages, carboplatin or cisplatin as a base. Now, for limited disease, the standard of care is a platinum-based chemotherapy together with radiotherapy. And this has been shown already several years ago that radiotherapy is giving an improvement in survival in this patient. So standard of care, chemotherapy, platinum-based, and radiotherapy for limited disease. Which kind of radiotherapy? Once daily or twice daily. Sometimes it has been a matter of discussion. Well, there is no major difference, but probably more toxicity with twice daily. What about extensive disease? As we mentioned before, chemotherapy, platinum-based, is the standard of care. And what about second line? To date, what we have approved is topotecan in second line. And this is based on the data that you see published in 2006, where topotecan outperformed best supportive care. And if we look, please, at the median overall survival, with topotecan of 6.5 months in second line. So keep in mind these 6.5 months of median overall survival for patients in second line. So where are we now with immunotherapy for small cell lung cancer? And I'm going to show you the results for second line and above with nivolumab, ipilimumab, and pembrolizumab, and in first line with atezolizumab, just a recent press release. What about nivolumab, ipilimumab? Now, this is the Checkmate 032 trial that analyzed two cohorts, non-randomized and randomized, to receive either nivo as monotreatment or combination nivolumab, ipilimumab, followed by nivolumab. And these are the first data that we have seen ASCO last year, where the overall survival at 1 year with a combination treatment reached 40%, and with a monotreatment nivolumab 27%. And as well, the 2 years overall survival 26 versus 14%. This is, for us, a major achievement if we look at the overall survival, because the patients here were above second-line treatment, which means patient with third-line or fourth-line small cell lung cancer extensive disease. Now, as we have done for non-small cell lung cancer to try to understand which patients to profit the most from such an immunotherapy, well, I have to introduce briefly, but this is going to be explained carefully at the end of this symposium, is the concept of tumor mutational burden. And this, we know it for different tumors as non-small cell lung cancer, that the highest is the tumor mutational burden, the likelihood is higher to respond to immunotherapy. And why that? Because as higher as is the tumor mutational burden, as more of the antigens that we have heard about this morning that are going to be presented to the immune system. Where is small cell lung cancer in terms of tumor mutational burden? And is one of the highest one close to the non-small cell lung cancer. So does this translate to results with immunotherapy? Well, yes. You can see here, first of all, the overall response rate using either nivolumab in blue or the combination nivolumab ipilimumab in orange. And you can see low mutational burden and high mutational burden. The response rate goes close to 50% in the combination for patients with high tumor mutational burden. Does this translate how in terms of survival? We're going to look now first at PFS and afterwards at OS. In the combinatorial treatments, nivolumab, ipilimumab, the 1-year progression-free survival with high tumor mutational burden achieved 30%. And this is what it shows also in terms of overall survival. As you can see, with a combination treatment of nivolumab, ipilimumab, high tumor mutational burden, with 1-year overall survival, 62%. And I'm asking to the several oncologists I've seen today here in the room, if we would have had to answer to these questions some years ago, the 1-year overall survival and second or third line setting small cell lung cancer to be so high. So probably we are going also to dissect, again, to profile which patients will profit from immunotherapy. As well, nivolumab also outperformed. We are awaiting the results of the CheckMate 331 study comparing second-line patients with standard chemotherapy. But as of this week, FDA approved the nivolumab in second-line setting for small cell lung cancer. What about the data with pembrolizumab? And these are the data from the Keynote 158 study, where patients who did not respond or had intolerance to standard chemotherapy received pembrolizumab and were treated for up to 2 years. Again, we try to dissect which patients would profit from this treatment. And in terms of in the Keynote trial, this was done based on the PD-L1 staining, positive and negative. And you see that we have about half of patients PD-L1 positive and half of them PD-L1 negative. And the response rate in the PD-L1 negative is by 6% versus 35% if we try to indicate or to find out which patients to receive this treatment. And this translates in terms of progression-free survival. What you can see is a 2.1, it was the PFS versus 1.9 months, but in terms of overall survival, 14.9 months. For patients who are PD-L1 positive receiving pembrolizumab. So can we, as we have heard before, for non-small cell lung cancer as well as for melanoma, can we introduce immunotherapy before, so at the first line, at the beginning of the treatment? And these is a study I'm going to present to you, just the press release, because the data will be presented at World Lung Cancer Conference in Toronto, September this year. And in this study, the evaluation was to combine the standard chemotherapy, platinum-based etoposide carboplatin, versus the combination together with atezolizumab anti-PD-L1. And the press release showed that there is an impact on survival by the addition already in the first line using atezolizumab in combination with chemotherapy. So I've already shown you studies that are going to change the way we treat patients from first line to second line. What do we have to expect to come? There are the future phase 3 trial to come, and these are the Keynote 604, comparing chemotherapy plus minus pembrolizumab, the CheckMate 451, again with nivo and ipi, and in concomitant treatment with chemo. The CheckMate 331, comparing the second-line treatment chemo versus nivolumab, and the IMpower 133 I've just shown you now, and the data will come soon. 2 of these studies have been also performed at our institution, and I would like to thank the colleagues from other hospitals for referral to these studies. What we have open to date in the University Hospital in Zurich is the Stimulus trial. This is an ETOP design trial where patients with limited disease, small cell lung cancer, will undergo standard of care chemoradiotherapy, and then in case of response, will undergo induction, immunotherapy, nivo ipilimumab, and then maintenance treatment with nivolumab for up to 1 year. So this trial is still open, and again, is the way we try to improve the treatment of these patients also in the earlier disease by combining chemotherapy, radiotherapy, and immunotherapy. I will move briefly to another way to do immunotherapy for small cell lung cancer. What you have heard now, this with checkpoint inhibitors, is the so-called active immunotherapy. And this now, what I'm going to talk to you about is how to use a passive immunotherapy with antibody conjugate. And the target is DLL3. DLL3, you might have heard in the keynote lecture this morning, is a target for neuroendocrine tumors. And it is especially expressed in small cell lung cancer and large cell neuroendocrine tumors of the lungs. It is DLL3, it is involved in the Notch pathway, and it has been evaluated as a target for treatment for small cell lung cancer in a first phase 1 trial with ROVA-T in patients who were undergoing more than second-line treatment, small cell lung cancer. And what the authors concluded is that patients who had here high DLL3 expression, again, we are trying to find which patients would profit from treatment, had a response rate up to 22%. This last year at ASCO, Carbone was also showing the data with ROVA-T in the phase 2 trial for patients who, most of them were in third line and expressing DLL3. And this is shown here. So based on the response rate, all patients with a response rate of 12 and the DLL3 high patients by 14%, where DLL3 is expressed in more than 75% of small cell lung cancer tumors. Again, this could be a way on how to improve the patient's treatment in a third line and how to select them. And there are ongoing trials targeting DLL3 together with anti-PD-1 antibody as well. I cannot not mention how do we treat mesothelioma, and this is because we have a major effort at our institution to improve the treatment for this disease. And this is due to the data I've shown you already previously with the median overall survival of patients of about 1 year after diagnosis of disease. Now, is mesothelioma a good target at all for immunotherapy? If we look at the tumor mutational burden, it is a very low tumor mutational burden to be detected in this disease. But at the same time, it is a tumor with a high reach T-cell microenvironment. As you can see here, is ranking as one of the highest one, which means that these highly inflamed tumors, can we reach this tumor? Can we treat it with immunotherapy? I'm going to show you now the data in second-line treatment with nivolumab, ipilimumab, pembrolizumab, and in first-line, some data, new data with durvalumab. Now, what about nivolumab versus the combination nivo-ipi for mesothelioma? And these are patients who have received after 1 or 2 previous lines of treatment for mesothelioma. So what you can see here are the data of the MAPS-2 trial. This is the nivo arm, and here you're going to see the nivo-ipi arm with an overall survival of 13 months in the second-line setting and not reached in the second-line setting with a combination treatment, which of course opened us the possibility to treat this patient with immunotherapy. And we took part to a study that has been, we are hoping to see next year the results, to use the combination of ipilimumab, nivolumab versus chemotherapy in the very first line setting. Now, what about the use of pembrolizumab? Very promising data came up from this recent phase 1 data study with a median overall survival. Again, we are talking about a second-line treatment of 18 months. So for this, based on this data on this phase 1, we have developed, the ETOP has developed a trial comparing in the second-line setting pembrolizumab versus standard of care chemotherapy, either gemcitabine or vinorelbine, based on investigator's choice. The interesting design of the study allowed that patient who did not respond to chemotherapy could cross over and receive pembrolizumab. And again, although this is by definition rare disease, mesothelioma, the study accrued 142 patients in less than 10 months. And this has been a major effort from colleagues from UK as well as us in Switzerland and the colleagues in Spain. Now, what do we have and what do we know now from data with in the first-line setting mesothelioma? These are derived from the DREAM trial. This is a phase 2 trial for a patient who underwent combination standard of care, cisplatin, pemetrexed, and durvalumab, and then underwent maintenance durvalumab. Well, these are the very first data that came ASCO last year, showing a very interesting median progression-free survival of 7 months. And if we look briefly at partial responses, these will 55 and 58% actually also confirmed responses is very promising. So meaning we are going to treat most probably already with immunotherapy patients already in first line. Before I will move and I will show you what we are going to develop in the first line setting in terms of clinical trial, I would like you to have a look at this curve that I'm always looking and we are always looking at. These are patients. And these patients here are the ones who responded at the beginning and then became progressive at this time point. So we're very interested to understand why do these patients develop this kind of resistance, and we want to improve the treatment for these patients. For this reason, we have established a mesothelioma mouse model to test possible combination to overcome such immunotherapy resistance. And these are just recently published data where by the addition of a chemotherapy, these are mice group who received either chemotherapy alone or immunotherapy alone and then responded to the combination of the treatment. What is of interest, and I would like to point out that has been just recently published also in JCO, is the role of corticosteroids in this setting. By giving corticosteroids from the beginning, hampered the effect of this synergy. Can this be translated into patients? And this we have evaluated as well in patients as a palliative setting. A patient who didn't respond to immune therapy, didn't respond to chemo, didn't respond to gemcitabine, and then underwent the combination and responded to it. Why that? Most probably we have, and we're still analyzing the results of this study, and we know that gemcitabine has an activation as a demethylating agent and might have increased the antigens, what we have discussed this morning and heard this morning, to be presented to the immune system. How do we evolve and how do we develop all the knowledge that we have, and what it has been shown is the role as well of bevacizumab as a immunomodulator, and this has been done by the ETOP to design this phase 3 trial with 320 patients to be randomized to use chemotherapy and bevacizumab versus chemotherapy, bevacizumab, and immunotherapy. We're very much looking forward to include patients in this trial. As I've shown you before, for small cell lung cancer, there are other ways other than checkpoint inhibitors to treat cancer, and this is what you've heard this morning as well with CAR T cells. The data with CAR T cells have been very disappointing for solid tumors for a while, and for mesothelioma, mesothelin-targeted CAR T cells didn't show any promising data at the beginning. We have developed a phase 1 trial targeting FAP, fibroblast activating protein, and this is to overcome the resistance to such CAR T cells to reach the tumor. We will inject these CAR T cells in the pleural effusion of patients with mesothelioma. And something similar has been done and is ongoing at Memorial Sloan Kettering with specific CAR T cells for mesothelin, where these CAR T cells are now given intrapleurally, and it has been recently shown that this has no off-target side effects, and promising data are coming, which means for you a lot of new results are coming with different ways to treat these rare tumors, but still occurring in our clinic, either with checkpoint inhibitors or other ways. And with this, I would like to thank all the colleagues here in the University Hospital in Zurich, in the University of Zurich, and the collaborating agencies and collaborating hospitals. Thank you so much for your attention.
Thank you, Alessandra. Maybe while people think about the question now, Kevin? Yeah, it should have come down, I guess.
I wanted to ask about the intriguing data you showed about the difference between activity when you gave a PD-1 inhibitor with or without a CTLA-4 inhibiting drug in the context of high mutational burden. Because my understanding, or at least my prejudice about how that might work, is that if you've got lots of mutations, you've got lots of tumor-reactive T cells, which are basically exhausted, and when you give a PD-1 drug, they reactivate. And a CTLA-4 drug is about either depleting Tregs or activating new T cell reactivities. How is this working? Because I wouldn't have expected those results to be restricted to high TMB in that context.
Well, it is still very much unclear, and it is still very much unclear also as well for melanoma. The point is that what we have realized is that during the last years, the effect of CTLA-4 antibodies has been discovered at the beginning to be related only to Tregs. And now we know that these are still fundamental for the activation, so for the very beginning of the activation of T cells. On top, we know now that CTLA-4 is fundamental as well for the reactivation of memory T cells. So most probably, we still don't know what is the effect with this antibody. So that's why I have to say that we are not yet there to understand this difference.
Alessandra, we will soon have also a trial on thymoma or thymic carcinoma. Yes. Maybe you want to say something about that?
Yes, there is the Novo team clinical trial. We're going to start soon based on phase 1 data that have been very promising with PD-1 and PD-L1 antibodies. The Nivo team will use nivolumab in the second-line setting for thymic carcinoma and B3 thymomas. So I warmly recommend for questions to contact us in case of possible inclusion of these patients. And of course, I hope this is going to be activated soon. It has been activated in centers outside of Switzerland and will probably happen by September this year.
Thank you. I see.
Alexander, sorry, one more question. It's about toxicity. So there is the hypothesis that if you treat, for example, a patient with lung cancer with anti-PD-1, you will have a different toxicity profile because the tumor antigens will share with the normal tissue. And when I saw the data, I'm not really convinced. So what is the latest information on this? Is the toxicity different in patients with lung cancer?
Yes, if we look at pneumonitis and we look at all the data with Nivo and Pembro, then the toxicity is higher than compared to the other groups, going up to 8 to 9%. Also, Rolf was mentioning the concept of other toxicity that can occur, like nephritis, hepatitis, and so on. But the pneumonitis seems to be one of the highest one compared to the other diseases. We have seen it. We have seen it in a context of the last treated 120 patients with anti-PD-1 antibodies, at least in 5 patients, grade 3 to 4 pneumonitis. But most probably there are more there that we might have also missed or diagnosed at the beginning. As Rolf was mentioning, the problem of knowing is the knowledge of such side effects, because when we were at the very beginning of this treatment, pneumonitis might have been misdiagnosed as lymphangiostis carcinomatosa, for example, knowing that a patient had lung cancer in advanced stage. I think we have to still evaluate this, and how to treat such pneumonitis is still, again, a matter of debate, although there are many different guidelines out there, the ESMO and the ASCO. But again, this is a subject for major interest, especially also for our groups and for patients with lung cancer, yes.
Yeah, I may add, though, it appears that cancers that have been associated with paraneoplastic syndromes, like particularly thymoma, thymic carcinoma, the early clinical trials saw tremendous toxicity. So this nivolumab trial that we are in is just for highest degree of thymoma or thymic carcinoma, and be very careful. The aim was, if the toxicity is not too much in this trial, then to go to Nivo-IPI. And then the same is with small cell lung cancer. There is very well characterized neurotoxicities with small cell lung cancer And our colleague from Lausanne has treated small cell lung cancer patients with immune checkpoint inhibitors first line, and she became, she could not use her brain function anymore. It must be in a nursing home, doesn't recognize the family, and it was felt to be a neurotoxicity related and associated with small cell lung cancer. So I think it's I don't know whether melanoma has a lot of paraneoplastic syndrome, probably.
Fortunately not. But,
vitiligo.
Yeah,
but
vitiligo. Yeah, but this is, yeah, we should go and see whether how frequent vitiligo you have in your patient population. You have no
we have, in 120, we have evaluated all possible IRAE, and there is no vitiligo.
Okay.
We have microdatis. Again, this again supports what you said.
Good. Then I'll close the morning session. You